So hi everybody. My name is Sarah Nutter. I'll tell you a little bit about my background and what I do here. I completed my master's and PhD in counseling psychology at the University of Calgary, and I moved to the University of Victoria over a year ago, and I joined the counseling psychology program here on campus. And so although my background is in counseling, it's really inherently interdisciplinary, and I do a lot of research in relation to weight stigma and its impact on health and healthcare. So in my presentation, I wanted to introduce you to the topic of weight stigma, just talk about its definition, the context in which it occurs, and the role of the media and our culture more broadly. I then want to review the consequences of weight stigma, so in particular, its impact on healthcare and its impact on the health of people who experience weight stigma. And then I want to just take a brief moment at the end to consider our cultural discourses versus scientific research findings, and to particularly ask ourselves, is weight as controllable as our culture wants us to believe? Are lower weights the healthiest, as our culture wants us to believe? And is weight loss as easy as our culture wants us to believe? Spoiler alert, no. We'll get there in a minute. Okay, so introduction to weight stigma. Weight stigma, or weight bias, or fat phobia, as it's often called as well, is really an umbrella term that's used to refer to the stereotypes, prejudice, and discrimination towards people with higher body weights. So stereotypes include, but are not limited to, those that you see here on the slide, including higher weight people as being lazy, unintelligent, gluttonous, unattractive, lacking in willpower. Prejudice moves beyond these stereotypes and includes discomfort or dislike towards people with higher body weights, the belief that weight is controllable and a personal responsibility, as well as the potential to act negatively towards higher weight people, which is realized in weight-based discrimination, which includes weight-based teasing, weight-based jokes, hitting, pushing, and physical barriers. So weight stigma occurs in all contexts of society as well as across the lifespan. So I wanted to give a bit of an introduction to where we can see weight stigma in our society in addition to health and healthcare. So in a recent systematic literature review that I led, my research team and I found evidence of weight stigma at all levels of education. So in preschool children as young as 3 and 5, all the way through to graduate school, and weight stigma as impacting the graduate school admissions process. We see weight stigma occurring in the attitudes of both peers and teachers at school. So peers in the form of weight-based bullying and social exclusion, and teachers in all sorts of forms. So generally in attitudes and expectations towards students with higher body weights. And this is occurring across teachers, not necessarily just physical education teachers. But we do see weight stigma in terms of, perceptions and beliefs of higher weight children as more burdensome, as less socially or academically skilled, and as just generally expecting less than their students. Researchers have also found lower levels of educational achievement among higher weight people. And my argument there would be, well, if you've had negative interactions with people throughout your entire educational history, it makes sense that you wouldn't want to continue through to high school or beyond. And we see that weight stigma in education negatively impacts students' well-being in terms of their self-esteem, self-worth, ability to cope with stress, anxiety, and symptoms of depression. We also see weight stigma in the workplace. Weight stigma acts as a barrier to gaining employment as well as to achieving promotion and success throughout one's career. Researchers who've looked at persistent wage gaps based on weight throughout the lifespan have found that after controlling for performance-related variables, weight-based wage gaps for men disappear, but have held true for women. So this research of these images you see here on the slide was conducted in Germany, and we can see 0 as representing a quote-unquote normal BMI. And for women of all ages, higher body weights are associated with lower wages, and lower body weights are associated with higher wages. And this trend continues regardless of job tenure. So there's, some variation here, but we're still seeing the same trend, regardless of whether or not a woman has been in her career for 1 year or 20 years. We also see weight stigma in relationships. So for example, peer relationships, as I mentioned before, social exclusion, bullying, teasing, things like that. But we also see weight stigma in romantic relationships. So who is regarded as an ideal partner can be very much weight-based. And these weight-based expectations can influence even married couples, where, if there's perception of negative judgment or negative feelings or not being the ideal partner based on weight, that can impact relationship quality. And we also see weight stigma in family relationships, in weight-based conversations that parents might have with their children, as well as in weight-based feeding practices. So parents may engage in intentional restrictive eating practices with higher weight children in an effort to control or modify their body weight. And all of these influences of all of these ways that we see weight stigma in our society really come down to what's happening at a broader sociocultural level. And researchers have called the discourse that's related to weight, healthy weight discourse. And healthy weight discourse is characterized by 3 interconnected messages. 1, that weight is an individual responsibility. 2, that lower weights are the healthiest. And 3, that weight can be easily modified via lifestyle changes. And we can see healthy weight discourse in things like our imagery on social media. So on the left-hand side of the slide, I have an image of what we call finspiration, which is something that's common on social media, as well as things like fitspiration, essentially what is supposed to be motivational imagery and words to help motivate somebody to do what they need to do to be thin. We see weight stigma in our public health campaigns. So this is a public health campaign here from Los Angeles, indicating that weight is as simple as eating less, which often comes along with a similar message of moving more. We'll get at whether or not these messages are true in a minute in our final section of looking at sociocultural discourses in relation to the evidence. But this kind of public health messaging is something that's very common both in Canada and the US. We also see weight stigma and these healthy weight discourse messages inherent in lifestyle transformation shows like The Biggest Loser, where people are put on extremely low calorie diets and are forced to work out for just incredible amounts of time each day to undergo rapid and very unhealthy weight loss transformations, but it's pitted as a positive health promoting activity and show. And we also see healthy weight discourse in the way in which celebrities and their weight is often focused on in our entertainment magazines, particularly for female celebrities in the pregnancy and postpartum periods. So we've learned about weight bias and weight stigma in general. We've had a brief introduction to it. What is the impact of weight stigma on health and healthcare? Well, it's a pretty significant impact. Researchers that have reviewed the literature have found that weight stigma negatively influences the healthcare encounter via negative communication, poor patient-centered communication, and poor language. So judgmental language, assumptions about patients with higher body weights, stereotypes coming through, and just overall providers not taking into account the patient perspective as much as they may with their lower weight clients. We also see healthcare providers having poorer perceptions of patients. So the negative attitudes and stereotypes that I referred to at the beginning of my presentation being very much present across all kinds of healthcare professionals. So these attitudes and stereotypes are well documented among physicians, student physicians, as well as nurses, physiotherapists, health dietitians, and other kinds of fitness professionals. We see in research demonstrating that fewer treatment options are often provided to patients with higher body weights. And so really a way of acting upon poor perceptions and poor patient-centered communication is offering fewer treatment options. And when you're doing that, patients are unable to make an informed decision. But often what's happening on the part of the provider in fewer treatment options is an assumption that this patient lacks the willpower or the motivation to do what they need to do in the first place. So why provide them with all of the treatment options? And all of this translates into less time spent with patients with higher body weights. In a recent study that one of my research teams and I conducted, we surveyed 400 family physicians from across Canada, and we found that 18% of our sample agreed or strongly agreed with the statement, "I am disgusted by treating patients with obesity." And although that is a minority of our sample, we felt that 18% was a really significant minority. And if we're thinking about this as potentially representative of the attitudes of physicians across Canada, this was a sample that was nearly representative. That is a lot of patients with higher body weights across Canada that are being impacted by such strong negative attitudes. 50% of our participants agreed or strongly agreed with the statement, "Patients with obesity increase demand on the healthcare system." And those who agreed or strongly agreed with that statement were more likely to believe that that demand is unfair and that patients with obesity should be paying extra for their healthcare. In a scoping review on the consequences of weight stigma on healthcare, colleagues of mine found that disrespectful treatment experiences were prevalent within research documenting consequences of weight stigma on healthcare. And that included patronizing tone on behalf of healthcare professionals, as well as insulting comments. Patients also reported that they felt that there was an attribution of all of their presenting concerns to body weight, so that healthcare providers were assuming that their presenting concerns were due to their weight and weren't looking beyond for any other alternative explanations and perhaps better explanations. There were assumptions about weight gain in terms of assumptions about diet and exercise without actually asking for that data, but assuming that patients were having a poor diet and weren't exercising. And patients reported, numerous unsolicited lectures about weight loss coming from their healthcare providers. And this literature can be really well summarized with the story of Ellen Maud Bennett, a Canadian woman who was feeling chronically unwell for years and continued to seek out help from her healthcare team and was repeatedly told to lose weight and she would feel better. And by the time physicians caught her cancer, she had days left to live. And so she wrote her own obituary and used it as an opportunity to call out this weight stigma in the healthcare system. And so, when this weight stigma doesn't have the deadly impact that it had for Ellen Maud Bennett, we see that it has just as dangerous and harmful potential consequences, in that patients will be ambivalent about seeking treatment or will delay seeking treatment, even if they know that they need to be going to the physician for healthcare. They will expect to be treated differently, which will reinforce low trust in their healthcare provider, as well as doctor shopping, which will impact continuity of care. And so what are the consequences overall for health when we're looking at weight stigma, not only from healthcare providers, but from various sources throughout the lifespan and throughout social context? Well, we see that weight stigma is associated with eating behaviors, so disordered eating behaviors, including restrictive eating behaviors, as well as binge eating. That puts individuals at a increased risk for eating disorders, both restrictive and binge eating disorders, which are also associated with experiencing weight stigma. We see physical health distress, including increases in blood pressure, as well as increased stress. And we know that chronic increases in cortisol levels, as well as increases in blood pressure, can have really significant and catastrophic effects on health. There's also psychological health distress associated with experiencing weight stigma on a day-to-day basis, including lower self-worth, poor body image, increased symptoms of anxiety, as well as depression, and poorer overall psychological quality of life. And all of this can contribute to reduced life expectancy. So researchers in 2015 looked at the experience of weight stigma on a day-to-day basis, and after controlling for weight and a number of other health-related variables, found that this everyday weight discrimination was associated with an increased risk of mortality. For individuals who more strongly internalize weight stigma and internalize the beliefs and attitudes in our society, we see an increased effect on health, so an additional reduced motivation to engage in physical activity, lower health-related quality of life, as well as higher body weight, increased risk for depression, anxiety, low self-esteem, and body dissatisfaction, and increased resting heart rate. So let's look at culture versus scientific evidence. So let's take a look back at the healthy weight discourse. Now that we know the impact that it has on our health and our healthcare, does what our culture wants us to believe about weight really match with the scientific evidence? And so researchers back in the early 2000s were interested in looking at the causes of body weight and the contributing factors. And so we can ask ourselves the question, is weight really an individual responsibility? Is it as simple as calories in versus calories out? And so starting with the basic energy balance or metabolism, researchers ask themselves, well, are there factors that contribute to energy balance? And yes, so they identified psychological ambivalence, physical activity, appetite control, and forces of dietary health as being related to our energy balance. And researchers then asked themselves, what are these factors comprised of, and what are the things that influence psychological ambivalence, dietary health, physical activity, and appetite control? And that led to this mess of over 100 different factors with 300 interconnections between those factors that researchers then categorized broadly into these seven categories. And so we can see that weight is incredibly complex, and that we need to consider not only our genetics, but as well as other health conditions that we might have and the medications used to treat those health conditions, our individual activity level, and our activity environment. Both of those are very much going to be influenced by, where we live, our socioeconomic status, a number of other factors. We need to think about food consumption, but as well as food production, the influence of the food industry, food marketing, hyper palatable foods, and individual psychology, of course, plays a role, but we can see that weight is much more complex than calories in versus calories out, and is definitely not something that is under control of individuals. The next question that healthy weight discourse leads us to ask is, are lower weights the healthiest? So researchers looking at mortality risk and hazard ratios have found a different picture than what our society might want us to believe. So all you need to know about hazard ratios is that the closer they are to 1, the lower the risk you have. So we can see here that folks who are put into the low overweight BMI category actually have the lowest level of risk, as well as those in the high overweight BMI category, which is contrary to what we might believe. We might expect to see that in the normal BMI category, because inherent in the word normal is, lowest level of risk. And so this risk based on weight and mortality actually takes a J or U shape, as we can see here in this figure, with individuals in the overweight category and obesity 1 really experiencing the lowest level of risk compared to those in low normal BMI categories, and mid-normal would be included in that as well. And so this J-U-shaped curve really is contrary to the idea of lower weights as being the healthiest, and as individuals in specific BMI categories as, experiencing a death sentence based on just their body weight alone. We also see that weight is just essentially not a good proxy for health overall when we're looking at other kinds of mortality research. So for example, when we consider sedentary behavior, we can see that individuals who are engaging in physical activity across the weight spectrum experience reduced levels of mortality risk compared to individuals who are more sedentary across the weight spectrum. And researchers from China also found a protective factor of weight in relation to blood pressure, with individuals with higher body weights and high blood pressure actually experiencing a reduced risk of mortality. And so, you know, these findings aren't final. They're not necessarily conclusive, but I think they paint a picture of weight and health as being more nuanced and as worthy of more nuanced research and discussion.
Dr. Nutter, that's your 2-minute warning.
Okay, this is my last slide, so that's perfect.
Perfect.
So it's also important to ask ourselves if weight is easily modifiable, which it's not. Researchers have known for years that 95% of individuals who lose weight do not maintain that weight loss over 3 to 5 years. In fact, they often will gain that weight back and more. And so it has led to the removal of intentional dieting and weight loss as a recommendation for the treatment of obesity in Canada. And I'll leave you with this quote from a slam poem given by Blythe Baird. And so it's this quote here: "If you develop an eating disorder when you are already thin to begin with, you go to the hospital. If you develop an eating disorder when you are not thin to begin with, you are a success story." And I think that really speaks to the activities that people do to intentionally lose weight and the impact that can have on our health. And that's it. Thank you.